Good afternoon all. Respected Dr. M.N. Patel, Provost, Parul University, Dr. Ajit Gangwane, Deputy Registrar, Parul University, Dr. Vandana Patel, Dean Faculty of Doctoral Studies, Parul University, Dr. Abhay Dharam C, Dean Faculty of Pharmacy and Principal, Parul Institute of Pharmacy, Dr. Guno Chakrabarti, Principal, Parul Institute of Pharmacy and Research, Dr. Lalit Lata Jha, Principal, School of Pharmacy, Dr. Kirti V. Patel, Associate Professor, Pharmacology, Department of Pharmacy, the MS University of Baroda, Vadodara. On behalf of Faculty of Doctoral Studies and Faculty of Pharmacy, I, Dr. Anand B. Pichadia, welcome you all in a webinar on the topic Knowledge Organizing Structure for Evidence-Based Medicine. I wholeheartedly welcome Dr. Kirti V. Patel, Madam, as an expert. Besides her busy schedule, Dr. Kirti has given us time to interact with students and deliver her talk. Let me introduce Dr. Kirti V. Patel. It is my honor to introduce Dr. Kirti Patel. Dr. Kirti Patel has completed her BPharm in 1996 and MPharm in 1999 from Pharmacy Department, the MS University of Baroda, Vadodara, and then completed PhD in 2009 from LM College of Pharmacy, Gujarat University. Currently, she is serving as an associate professor in the Faculty of Pharmacy, Pharmacology Department at the Maharaja Sayajirao University of Baroda, Vadodara. She has in her credit 53 publications in various reputed national and international journals. She guided 75 MPharm research projects and 4 PhD projects are currently ongoing. She have groomed students for various state and national level competitions. She contributed to Gujkos funded research project as a principal investigator. She delivered lectures in various platforms of state and national level. She completed Gujkos funded research project and delivered numerous. She is associated with numerous institutional animal ethics committee as a CPCSE and Omni Institutional Human Research Ethical Committee as a member secretary. So with this, I would like to request you, madam, to start the session. Okay, madam.
Thank you, sir. Is my screen visible?
Yes, Kirti, it's visible.
Yes, visible, madam.
Since we are in online mode, this disclaimer becomes an important aspect. At the outset, I would like to give a disclaimer that the contents of the slides are intended only for educational purpose and purely for personal use. The information which is given in the presentation has been obtained from various sources which are believed to be open educational resources, and whatever views are presented, they are solely of the presenter. And I would like to stress that today I would be discussing 2 clinical cases, and we'll try to reach to an answer to those 2 clinical cases on the basis of the various steps which are involved in evidence-based medicine, organizing the available knowledge which is present in various evidences. So to begin with, but before I begin, I would also like to pay my tribute to Dr. APJ Abdul Kalam, former President of India, on his birth anniversary. And today, 15th of October, is also being recognized as World Student Day in his memory. It is aptly said that learning gives creativity, creativity leads to thinking, thinking leads to knowledge, and knowledge makes you great. And that is what we are going to do today, that we are going to organize the greatness into a definite structure, generate various evidences, and depending upon that, the critical decision for medicines should be taken. And that is what we are going to try to emphasize on, using knowledge organization structure for evidence-based medicine. In today's world, there is so much information explosion, and this is because there is a rapid increase in the amount of published data, published information, and because of this abundance, there is a lot of chaos. There is a lot of data which is to be handled, and it has eventually led to information overload. Information overload has led to disorganization and eventually stress. On the screen, you can see it's a small screen and there are only a few jumbled words. But when you see at those words, you get confused because there is no connection in between them, because it is an unorganized collection of some data. As soon as you organize them, you come to certain meaningful conclusions, and it is very evident. The screen looks clean, and at the same time, you can reach to some critical conclusions that there is a list of vegetables, some non-vegetarian items, something related to dairy products, and then there are certain groceries also. So, same thing when we apply to the data which is available in the medical domain. Here you can see there is an exhaustive list of approved antihypertensive agents. And if you're supposed to select one from this for a particular patient, then doesn't it require a very critical decision? It has to be based on sound scientific medical evidences. Preferably, it should be successfully attempted before, and whatever the recipient receives, it should be safe and efficacious to that recipient. So, but why are we talking of all of these things? Haven't these questions been answered previously? Haven't the discussion regarding medicine knowledge organization and their implementation on the basis of evidence opened up well before what we are dealing today? Yes. There has been a lot of tragedies, the well-known tragedy, thalidomide tragedy, and the deaths occurring from numerous other applications of untested procedures, products, hypotheses in clinical practice have eventually led to a systematic evaluation of various studies. There was always an urgent need of testing efficacy, safety, suitability of the drug in the clinical application, and then depending upon the outcomes, formalizing rules for grading the quality of whatever evidence has been arose. And we have landed with lot of clinical judgment. But despite the efforts, even as late as near as 2003, there was a study published in USA. It suggested that the patients who are affected with at least one of the common medical disorder is likely to receive an appropriate care only half of the time. That means half of the time the judgment is wrong. The clinical judgment might turn out to be otherwise. Now, who is to be blamed? No one has to be blamed, or everybody has to be blamed. I would like to acknowledge at this particular step that the poor clinical decision, whatever has been made, reflects to a considerable degree on the shortcomings in the ways by which the how they are being taught, and there are some shortcomings in the methodology of teaching. That is one which I can think of. Then there might be some shortcomings in the accumulation of the evidences or compilation of those evidences, leading to hindrance in reaching to a proper clinical decision. So, how do we educate all of them? Yes, there are ways and means, because we have been dealing with this problem since ages, and therefore number of methodologies have been developed, and there are CME programs, there are a number of published references available which deals with CME, like US Pharmacist, then Pharmacy Times, then there are drug topics. Number of such publications are available which go for continuing medical education. There are clinical practicing guidelines which are coming since a long time. We had JNC 1 to JNC 7, 8, and then 9, and then we had the ACC guidelines. Then there are a number of reports where experts have always given their advices, and apart from that, there is a lot of reading material available in the form of books, textbooks, conference proceedings, such webinars. So number of things are available, and we are being continuously educated. Then where is the problem? The problem is that this has to be continuously updated. And if it has to be continuously updated, then how all the custodians of medicine, say doctors, pharmacists, and nurses, how do they remain current as these approaches are continuously changing? What is the solution? Solution lies in a scientific approach, having a scientific approach to medical practice, which has to be based on these 4 pillars guided by 3 different reasoning principles. The 4 pillars include that your practice should always be eminence-based. That means you should have the superiority of a particular practice, and which has to be established through randomized controlled trials. You should have a definite evidence. Second, you should have space in the guidelines which allow you to incorporate the decisions which the experts might come while using the therapy based on the guidelines. So while using the therapy also, they might come out with some new conclusions, and there should be provisions in the guidelines to incorporate them. So experts or practitioner experience based incorporation should be there. Third, depending upon the causal thinking, there might be certain causal thinking where you don't have answers, and there might be a causal thinking, and that opinion-based medicine should also be incorporated under conditions जहाँ पे कोई rare disease हो, rare condition हो, emergency condition हो, such provisions should be made. And last but not the least, the client preference, that you should always encourage decisions which consider patient values and belief. So client or patient preference should always be considered whenever you're having an approach, a medical practice. And when you are doing all this, you have better improved patient outcome. So if you have the best evidence, you can have the best practice. And this is based on three reasoning principles. Everything has to have a reason. So it should have a procedural reasoning, it should have an interactive reasoning, it should have a conditional reasoning. Procedural reasoning means you should think of what physical performances of the patient will be affected by adopting a particular procedure. Interactive reasoning means you should consider the patient a person first and then a patient, right? And conditional reasoning means you should also focus on the outcomes or prognosis, what will occur by utilizing this particular approach. So when you incorporate all of these things, the eminence of the evidence, when you incorporate an expert opinion, when you incorporate a causal opinion which is valid in the current context, and when you have a client preference, a patient preference, you might, guided by procedural, interactive, and conditional reasoning, you might have an improved patient outcome. And that is being referred to as organized evidence-based practice or medicine. Evidence-based medicine, by definition, is a conscientious, explicit, and judicious use of current best evidence in making decisions about the care of the individual patient. It encourages utilization of the evidences from the clinical research to support a clinical decision making for the individual patient. So it collects the evidences from the clinical research. Depending upon those evidences, it makes a clinical decision, and that clinical decision is always made for a particular patient. So evidence-based medicine is the best integration of research evidence with clinical practice and patient values. If you have all three, then you are going to have a paradigm shift in medical approach to patient management. It has been adopted, and it has been adopted as evidence-based medicine or evidence-based healthcare, and it is, as I said, it is the integration of research evidence, clinical expertise, and eventually the central role is played by the patient unique values and circumstances. So once we have understood the definition that it involves research evidences, it involves decisions on clinical expertise, and then you involve the patients also, there are certain steps of following the evidence-based medicine process. How do you reach to an evidence-based medicine in a clinical scenario? When you look at this table, which has been taken from a reference itself, it appears a little confusing. But there are 5 steps, that is what is clear. And I have simplified those 5 steps into 5 A's of the steps of EBM process, the evidence-based medicine process. You are supposed to ask, acquire, appraise, apply, and assess. Assess. You are supposed to ask a focused clinical question whom you are supposed to answer. So it should be an answerable question. You should acquire that from which evidences you will answer this question. You need to critically evaluate the evidence, so you need to appraise the evidence. Then whatever evidence you have got it and appraised, critically evaluated, you can apply it to the clinical expert. You can apply it compiling them with clinical expertise and patient values. And once you have applied, you have to go for follow-up, you have to document, and then you have to reach to a conclusion. And if required, you can upgrade the evidences from where you had started. So this is the process. We'll understand individual steps of this process utilizing the 2 clinical questions, as I previously said. So beginning with the first step, that is, what are the common types of clinical question. I will discuss all the 5 steps in relation to 2 clinical scenarios. The first step, that is, what are the common types of clinical question. Again, the reference gives a clinical set of questions. I have summarized it in a little easier form, easy to understand, that you are gathering evidences or you are trying to have questions on clinical evidences, diagnosis, prognosis, therapy, prevention, education. And if you can categorize the questions in these categories, then you might reach to some conclusion to formulate a question, because the first step of EBM is to formulate a question, a clinical question based on the clinical scenario of the patient, so that that can be answered. So the clinical scenario is, we take up the first example, that you have a 55-year-old female patient with a prior history of hypertension, and the patient presents to the clinic for a follow-up. Since the patient is presenting to a follow-up, that means the patient is already on antihypertensive drug, and the patient has a borderline risk of 5 to 7.5%, 10 years ASCVD risk. She asks for advice regarding the use of statin, as she has Googled it to be protective for heart failure. So this is a common problem, that people can have number of resources. As we are having evidences, they might also be having evidences. So here, when you look at this scenario, you need to formulate a question depending upon this particular case. Before formulating a question, you should question yourself with certain background question and certain foreground question. Background questions are general questions related to the knowledge of disorders. So if you see, there is a hypertension, there is a risk associated with ASCVD, and the patient is inquiring regarding heart failure. So when you're collecting the background information, you should have a general knowledge regarding the disorders, that is hypertension, ASCVD, and heart failure. You should also know the diagnostic tests, so that you can evaluate whether the patient is appropriately diagnosed. You should know about the available treatment for the disorders, and you should also know, since the patient is also posing a question to whether it would be protective for a heart failure, so patient is anticipating that heart failure might occur. So you should also know regarding the causes of the disorder. And depending upon the background question and the clinical scenario which has been presented to you, you can have certain questions for foreground, where on the basis of which you will develop a strategy for treating the patient. And when you're formulating the question after doing such background check, you focus on PICO, P-I-C-O. Once you have the background questions answered and you have decided some foreground questions, you focus on formulating a question by focusing on PICO. PICO is, P stands for patient. So what was the patient in the clinical case? It was a controlled hypertensive adult female with a risk of 10-year ASCVD. What was the intervention she was inquiring? She was inquiring regarding statin. With whom would you compare? You would try to compare it with placebo, because right now she's not having anything. And you would go for searching of evidences to find out the outcome, that what would be the possible outcome from those evidences which you search, that you want to know whether it is going to prevent heart failure. So when you have this clinical scenario divided into this PICO, you come to a question that, does statin administration offers protection from cardiovascular disorder in controlled hypertensive adult with a 5% to 7.5% 10-year ASCVD risk? So the first step of EBM has been answered. We have been successful in generating or formulating a question which needs to be answered through the EBM process. Similarly, I take a second clinical scenario. So we will formulate 2 questions. This is a second clinical scenario where you have a 60-year-old male patient with no prior history of any cardiovascular event. So it's a healthy patient. Presents to the clinic for a follow-up. 60-year patient hai, so routine checkup. And he asked for advice regarding use of aspirin, as it was recommended for his friend who had a heart attack recently. These are the common scenarios. People have more than one doctors, right? So there is a probability that, so depending upon this clinical scenario, you formulate a PICO. So the patient is healthy adult male, intervention is aspirin, Comparison is with placebo, and what outcome you are thinking of? You are thinking of whether administration of aspirin will result in prevention of cardiovascular morbidity and mortality. So the question which you formulate from this clinical scenario is, does aspirin administration offers protection from cardiovascular disease in healthy adults? So now we have finished the first step of the EBM, looking at the two clinical scenario that we have formulated two questions. We will try to answer this question by the time we reach step 5 of EBM. So now next is the second step, that you are now supposed to search for evidences. You are now supposed to acquire certain evidences from where you can find answers for the question that you have formulated based on the clinical scenario. So now, if you have a broad question, just a foreground, background questions there, so for that you can always, the best place is search a textbook, right? A good textbook, right? And for the EBM focused clinical question, we need to look into the medical literature, right? It can be, I'll discuss the various forms of literature also. So if you want a background question, if you want an answer to the background question, then you better refer textbooks. There is no taboo to refer journals, but yes, better refer textbooks. And if you have an EBM focused clinical question, refer the literature, medical literature reported in journals, guidelines, and the various types of evidences which we will discuss over here. There are three major types of evidences. One are the filtered resources. The second one is the unfiltered resources. And third one is the background information or expert opinion. So in order to answer the question 2, the step 2 of EBM, we are supposed to look for evidences in various resources. So filtered resources are of three types: systematic reviews, critically appraised topics, critically appraised individual articles. Unfiltered resources are randomized controlled trials, cohort studies, case control studies, case series, and case reports. And as I said, if you want a background information, it has to be textbooks, point of care resources, conference proceedings, webinars. From that, whatever you get, that becomes the background information, right? So now we will discuss the individual resources. The first one, that is a filtered resource. So there are three types of resources: filtered, unfiltered, and the background. So when you talk about the filtered resources, as you see, there are three types, and filtered resources are usually having that much strength that they can set the stage for recommendation for practice. So these are the sources where you find maximum answers. Now, it is not that you don't find answers in books or unfiltered resources, but yes, when filtered resources are there, they are based on critical evaluation. In that, you have three types: systematic review, critically appraised topics, and critically appraised individual articles. When you're talking of systematic review, they ask a specific clinical question, right? So when you have one review, in that review will answer a specific clinical question, better suits you, right? Because we are also trying to answer a specific clinical question. Then it uses only those sources of evidences which are well done. It does not rely on one source of evidence. It prepares a review by looking into number of sources of reviews, number of sources of studies, and then it compiles, or it performs a meta-analysis and reports that. And when it is reporting a meta-analysis, when it is compiling the evidences, it compiles evidences only from those resources which are well-done studies, right? So it has to be a randomized controlled clinical trial from that only, but it performs a meta-analysis. And there is a probability that it might also go for a review, literature review, and a very comprehensive literature review. So it helps you answer the questions in a better light of evidences. And it never uses, or it eliminates, the poorly done studies. Whereas the second type of references or resources, they are usually focusing on multiple type of resources. They are focusing on multiple type of resources. That means multiple type of studies. That means it can be an experimental study, it can be a qualitative study, it can be an outcome study. They can have a number of studies, and then depending upon that, they might synthesize, and they might have, since they are different types of studies, they might be a cohort studies, they might case control studies. So it might be randomized controlled studies also, or even unrandomized, non-randomized controlled study. But they synthesize, they are evaluation, they synthesize their recommendation from these multiple research studies, and they prepare a short systemic review focused on a particular topic. This one answers a specific question in the topic, whereas this one answers a question, this one answers a topic. So this is more broader, and this becomes more and more narrower. Critically appraised individual articles, the name itself suggests that it takes an individual research article, evaluates it, and then prepares a short synopsis. So these are three different forms of filtered resources, and these are the sources from where you can get the get the evidences. Suppose you want systematic reviews, then you can get from these databases. Some of them are paid, some of them are freely available. So from them you can get the evidences. Then the second one is the unfiltered resources. When you're having an unfiltered resources, you should always remember that since it is an unfiltered resource, because no meta-analysis has been performed by another person on that, it is necessary that you become a reviewer and find out whether the information that you are collecting from an unfiltered resource is valid and reliable. Now, valid and reliability will depend upon your clinical question. The study might be completely valid, right? But it might not be valid to the clinical question that you are thinking of. So it is necessary that in such conditions, when you're using an unfiltered resource, you evaluate that resource for its validity and reliability in context to the clinical question that you have formulated. So there are randomized control trials, cohort studies, and case control studies. Randomized control trials are, in this, since the subjects are randomly assigned to both the intervention group, that is a treatment group, and the control group or the placebo group. So you are reducing the bias. Then at the same time, you are allowing comparisons between the intervention group and the control group. So that is also a better approach. And most of the studies are double blind. So that eventually reduces the bias. So that is why randomized controlled studies are always preferred. And if number of randomized controlled trials with the same clinical question are meta-analyzed, then they become a filtered research. Cohort studies are usually prospective in time. Here you have a group which is exposed to an exposure. Suppose you take a group of patients who are exposed to COVID. So that is an exposure. And then you take a control group which are not exposed to COVID. So that is a non-exposure group. So that becomes a control group. And then you compare them in the prospective studies that the patients are followed up, the subjects are followed over the period of time to find out what outcomes are there. So this is the exposure-based study. You decide an exposure, prepare a group, compare it with a control group which is not exposed to that exposure, and then you can have multiple outcomes which are being graded over the period of time. So it is a prospective study. It will take a long time to have the answer generated, but the answers are really definite and they are reliable. Coming to case control studies, it is exactly opposite to that of the cohort studies. You take a population which is having an outcome. Suppose you take a population which is having graying of hair. The hairs have turned white. And you take a population in which the hairs have not grayed. And then you go for a retrospective study to find out what exposures those patients had. Okay, those patients, those population in a control group where the hairs had turned gray, you go and find out their stress level, their diet, eating habits, their exposure to the various pollutants, and then you can have those exposures. So this is outcome-based grouping. Case control studies are always outcome-based grouping, and cohort studies are exposure-based grouping. Cohort studies are prospective, whereas case control studies are retrospective. Cohort studies are taking a longer time, whereas case control studies, since it is retrospective, you can finish it off within a short span of time and come to a conclusion. But conclusions in case control studies, because internal validity becomes a greater problem, therefore the conclusions are little less reliable. And then there is the last one, that is the unfiltered source, the case series and case reports. The name itself suggests that case reports, you take only one individual patient without any control group, and whatever reports have been generated from that individual patient, you put it in evidence. So this is less scientific significance, but it has to be recorded because this will compile more number of evidences over the period of time. And what are the sources from where you can obtain this? Sources, I have mentioned them. Apart from that, from where Coming to the third resource, evidence and the evidence with books which are there are with intended to so such reference the expert have got number of evidences. You have an unfiltered resource, you have a filtered resource, and you have the background information. And then you have number of questions also. We have formulated the questions also. Question can be related to therapy, question can be related to harm, question can be related to etiology, question can be related to diagnosis, question can be related to some symptom, right? So it can be, question can be related to cost, question can be related to quality of life. So you can have number of questions. Responding to number of questions, you have so since evidence-based medicine practice is being continued since long, they have come to certain conclusions that if you want an answer about therapy or harm, then the gold standard of reference control trial, no meta-analysis has been. Cohort are cohort studies, case control studies, case series, expert opinion. So you can see that for different questions, there are first line evidences, there are second line evidences, and there are third line evidences. That has been summarized in this table. For various clinical questions, you have suggested research design. So we have reached to a conclusion of the second step of evidence-based medicine. We have formulated the question, and then we have got the evidences, which evidences should be relied on for a particular type. Upon these evidences, whatever these evidences have been categorized as some evidences for therapy, some evidences for etiology, and so on, these evidences have also been leveled based on their strengths, right? Based on their rigors, based on the quality, right? And these are systematic reviews, having number of system. Level 2 are a single well-designed randomized clinical trial. Level 3 are well-designed clinical trials. Level 4, well-designed case control and cohort studies. Level 5, systematic reviews of descriptive or qualitative. Level 7, evidences of opinion of, that is the expert opinion. Also, books are also being referred to as expert opinion. Evidences you are using, they are also being graded according to levels. This also, that if you see, if you say double blind, experimental protocol, and careful have to being applied systematically and super internal validity means whatever factors that the correctness of the trial, the study. So you have incorporated all the optimum factors in the trial, and depending upon that, you will have outcome. So those outcomes, that is the applicability of this research, will be referred to as the external validity. So now what happens is that if everything is optimally organized, and then you will have a very good perfect relationship. Whatever outcome you get from that will have a very good relationship with the cause. But in the clinical scenario, external validity will be in consensus with each other. But when you go is number available, which patient, when you as a probability of the patient, probability, the amount of stress level when you're conducting clinic might be observed in the patient in such strict relationship between the internal validity and clinical, because one is less good and best have importance applied to everybody, and most systematic review, you can go down, you can go for critically appraised evidence. If you can go down and go for critically appraised articles, if you do not find evidence over here, you can case control studies and background information. And pyramid, and where it includes all different types of research. It includes the outcome research, and then was based on the research, experimental research, and it was planned, so it will have so internal validity also going to look for say the case control studies, then expect the so their internal validity at the side of that overlap single subject study, which is of least significance, coming to controlled clinical trials, randomized clinical trials, and then the meta-analysis. And the same goes with the other sides of the pyramid. And when you are coming to a conclusion from this pyramid, you will take into consideration the level of evidences from all aspects. You will not level of evidence. You will reach to the we have finished with formulating a question, and we have finished with searching for an evidence should be collected on the basis of evidence pyramid. Now, how do you evaluate those evidence? How do you critically appraise those evidences? Have to be appraised on the basis of validity, impact, and applicability. Validity means, is the population representative of the population that you are considering, of the clinical question that you are considering, and was it a random selection or wasn't it a random selection? Was there an adequate follow-up, and whether the outcomes which have been measured were unbiased? If you have plus an answer, if you have a positive answer for all of them, then the validity of that study, right? Impact means, is a significance of that particular evidence in response to your clinical question. So you need to have the impact, the size of the benefit. And the results of the study be applied to your patient, the patient under question. Depending on application apply things to with the patient values, and depending upon that, the final decision will be made. So here you go for a CAT analysis. CAT analysis is considered to be a critically appraised topic. In this, you define a clinical scenario. This is the fourth step of EBM, where you define a short sentence about the problem. That we have already done. We have formulated a question. A because gather related. Depending upon the define a finding, okay, what you have concluded from all of these evidences, and then you have a bottom line. And when you have this picture, it is being referred to as a CAT. And depending upon the CAT analysis, that is the fourth step. This is the conclusion that you and given by different systems. There is a grading system, there is a sign system, there is a sort system. I'll refer to the we'll discuss the. We are dealing with the fourth step, where we have already formulated a question, we have gathered the evidences, we have evidences and graded them in the research pyramid, and now taking into consideration the patient values, CAT have one about the evidences which we have collected, and then we will have a conclusion based on the SORT system, the strength of recommendation taxonomy. So the strength of recommendation taxonomy, they have classified it as class 1. Class 1 is the strongest recommendation where benefit is highly greater than risk. Class 2A class benefit equal no risk, and this is class 3. Again, harm in certain condition, it is written class 4 also. Harm strong and risk is greater than the benefit. So these are the recommendations which you can do. And what are the levels of A? That means you have a high quality evidence with meta-analysis. Level B, you have a moderate quality evidences with randomization. You have level BNR, you have a moderate quality evidence. Level C, you have a limited data with randomized or non-randomized, but they are observational studies, they are cohort studies. C, EO, that is the expert opinion. So if you can see these levels and these recommendations, I have taken from SORT system, and they have defined the recommendation. Class 2A is moderate. Benefit is but very strong and graded from the evidence pyramid. Are independent of each other, and how they are independent, I'll show you. We had a case of 55-year failed the first case, and we had generated a question that is the administration of statin offering some protection in cardiovascular disease in controlled hypertensive adult. So that was the question which was formulated. Then we have got the evidences, and when we have got the evidences, we have got evidences which are of the nature of BNR. So level of evidences is B, non-randomized. Level of evidence is B, non-randomized. That means you have moderate quality evidences from one or more well-designed, well-executed, non-randomized studies, observational studies or registry studies, and meta-analysis of studies, right? This meta-analysis has been performed. So the evidence which you have gathered for this particular question, the question that we had formulated, is of the level of evidences BNR. And then you are formulating the recommendation, the categories of recommendation, and you are putting a conclusion. I said that we have a short sentence about the question, then we have focused on evidence, and now whatever search finding are there, they have to be mentioned, and then depending upon that you will give category of recommendation. So the question has been formulated, then you have the level of evidences. From the level of evidences, you write what the evidences have been collected. If you can see, the patient of our age group is an adult female, right? It's an adult female above 55 years of age. So if you can see, it comes over here in adults at borderline risk of 5 to 7.5%, because we have an adult population, adult female with an ACVD risk of 5 to 7.5%. So the evidences say that whatever evidences, the evidence level of evidence that we have collected is of B, level B, non-randomized study. And in that, the statement goes like this, that if the patient is having a borderline risk or an intermediate risk, then it is reasonable to use an additional risk enhancing factor to guide decisions about preventive intervention, statin therapy. Yani they are saying that you can give a statin therapy, but before that, you use additional risk factor. The patient has already been categorized as a borderline risk with 5% to less than 7.5%, 10 years ASCVD risk. Yani preliminary risk assessment is done. But in order to add a new drug, you need to go for additional risk enhancing factors. And those additional risk enhancing factors should be evaluated in order to guide the decision. And those are, say, the patient should be evaluated for C-reactive protein, whether there are inflammatory changes occurring in the patient. Then the patient can also be evaluated for a lipoprotein which is atherogenic, so lipoprotein A. The patient can also be evaluated for the ankle brachial index. You try to measure the blood pressure at the ankle and at the brachial level, and if the ratio is 1, then it suggests that the blood flow is normal. So if you do such additional risk enhancing analysis of such additional risk enhancing factor, and even if they point to the borderline risk, then statin therapy should be incorporated. That is what the studies have concluded. And what is the level? So depending upon that, you find out that the risk is, the benefit is greater than the risk. So you give a level of you give a category of recommendation, that is category 2A. Benefit is greater than the risk. So you have formulated a question, you have generated the evidences, or you have evaluated the evidences, and you have found out that it is of level B, non-randomized. And from that, you have generated a statement which was found in the evidences. Depending upon that, an action plan was generated and it was implemented, and it has to be implemented for that patient. And the recommendation is moderate. You can administer to such patients, right? You can administer statins to such patients. And since the patient in this case is asking for adding a statin because the patient has Googled, you need to offer a definite evidences. So additionally, you can also go for, in order to have a patient-physician discussion on the addition of a new drug therapy, you can go for also measurement of coronary calcium stores. Coronary calcium stores have been listed to be a direct factor associated with contraction of coronary arteries, leading to compromised blood flow. So there is a probability that if you can evaluate all of these things and statin, and then if it has a positive impact or a positive risk enhancing factor has been identified, then the decision to add a statin can be taken for that patient. So I hope the answer is clear to the clinical question, that you had a clinical question. Depending upon that, you performed a PICO, reached a question, and then you evaluate it, then you search for evidences, and when you put it in a evidence pyramid and found out it to be a level B evidence, which is a non-randomized study, then you reach to a conclusion from the evidences, and then you recommended that it is a 2A category of recommendation. And how did you come to that? That is what is being shown here also. That if you see, the weight of ASVD net benefit from statin therapy is greater than the risk. Risk is there. It is not that it is level 1 recommendation nahi hai, level 2A recommendation hai, but risk is less than the benefit. Benefit is more than the risk. And you can see that stroke, myocardial infarction, heart failure has been diminished by these many persons. And this has been obtained from the references which are of level B, non-randomized. So then, depending upon that, you conclude that you might add a statin depending upon the discussions with the patient and the additional risk, screening of additional risk enhancing factor. So that was the first scenario. Second scenario, we had already formulated a question regarding aspirin use, and the same way the references are to be evaluated, and then the level of evidence was A. That means you had a very good level of evidence, but the recommendation was 2B. Agar level of evidence A hai, to recommendation should be 1. But no, it is not like that, because when you saw into those level evidences, it was observed that even though they have said that low dose aspirin might be considered for primary prevention of ASVD among adults of 40 to 70 years of age who are at greater risk, but they should not have an increased bleeding risk. So there is always a risk. So that is why the level of evidence, the category of recommendation has taken that point into consideration and said that there is a risk. Benefit hai, lekin risk bhi hai. So if you can evaluate the risk, nullify the risk, then you can administer. So that is a category 2B level of recommendation. Category of recommendation is 2B, that is moderate, and level of evidence is A. So looking at both the scenarios, we have reached the conclusion that statins can be administered when to that particular patient if you can evaluate and have a positive, the role of some additional risk factors who are enhancing ASVD. And if in this patient, you have to evaluate ASVD and also see whether there is no bleeding risk. If both of these factors are applicable, then you can have the recommendation to give aspirin. So this is how the conclusions are reached for the clinical question. So we have finished with the 4 steps of the EBM process, and coming to the last one, that how do you assess the evidence-based medicine? Assessment is just once you have already implemented, you have to go for follow-up, keep an appropriate record, and then you have to utilize those evidences which have been generated after implementing the evidence-based medicine to formulate an upgradation of the recommendation or support the recommendation that you have made. So you have to go on collecting 2 things, means you have to work on 2 aspects. You have to keep on collecting the evidences, and depending upon the evidences which have been collected after administration of the drug, to the clinical scenario that we had dealt, we can have a detailed instruction component. So we need to assess what is the effect of intervention. We should also check the validity. We should have some publications also associated, because other people must also have been working on the same direction. And depending upon that, we can upgrade the level of evidences, right? So when you have this, when you go for collecting evidences after the implementation of EBM, you can also have evidences for either upgrading or degrading the level of evidences. And then depending upon that, you have to give instructions, and these instructions has to be localized to the patient, localized to the local condition, localized to the general lifestyle and the geographical situation of that patient also. And depending upon this, you can upgrade or degrade the recommendation protocols. So the 5th step of evidence-based medicine is compiling more evidences on the therapy that you have advised on evidence-based medicine, and then upgrade the level of evidence and the grades of recommendation. So in conclusion, what we can conclude from this, that the custodians of the drugs or the researchers should always have a specialty group, and they should produce a central repository of all the evidences. So every specialty group, say diabetes, say cardiovascular, say CNS, so all of them should have a specialty group, and they should always keep on collecting the evidences, and they should be updated. Then for individual diseases also, you can have the evidences collected, and both of these evidences should then be put at the central resources, and then the central resources should be taken into consideration while formulating a guideline. There should be a national guideline, and there should be a worldwide guideline, there should be a national guideline, and there should be a regional guideline. And that is what has been implemented. If you see the ACC guideline, American College of Cardiology guideline for the drugs used for the treatment of hypertension, it is a wonderful guideline based on all the levels of evidences and the grades of recommendation. So this is how, if you can update the evidences based on the evidences that you generate by applying evidence-based medicine, you can go on upgrading the evidence-based medicine approach. So to conclude, that we have learned the lesson, and we should learn the lesson, and we should act upon that. If we don't learn the lesson, it will repeat itself. And we have to identify that with proper medication, everybody will live happily ever after. Thank you.
Thank you, madam. Now the session is open for question by the guides or students to the madam.
Very nice session, Kirti madam.
Thank you, madam.
As always, you explained in such a lucid way and very easy to understand.
Thank you. I had tried to be very preliminary so that everybody understands.
Yes.
Yes, students can ask questions to madam related to the research or any other thing related to topic.
Yes, ma'am. Good afternoon, ma'am. Ma'am, actually, I want to ask you give some suggestions regarding PhD project. Actually, ma'am, I am interested in doing some work on herbal plants. But whatever the literature review that I have done, I found many of the medicinal plants that has been most of the work has been done on the most of the plants. So, ma'am, how can I go for the selection of the plant, and what is your suggestion regarding that, ma'am?
See, this I do not know whether I might be right, I might be wrong also, but whenever we decide a clinical a research question, it has to be on the hypothesis. It has to have one problem. It should have a background problem, and depending upon that, you generate a hypothesis. If the current drugs are available and it is working fine in a disorder, then you are not in a position to find out the problem associated with those drugs or disorder. Then how can you answer a question? You need to find out what is the problem. If the problem is not identified, you cannot have a research. So that is what my take is. Even we are working on herbals, but the things which what is the current problem? Is there a current problem? So suppose we talk about nephrolithiasis. Then is there a current problem with the available drugs? If we can identify the problem associated with those drugs, it can be from the natural resources also. Then you can target that question, and depending upon that, your selection will be there. So I think that is a wrong method. You first select a plant and a disease, and then you work out and find out the effect. No, it doesn't go like that. Research has to always have a question in mind, and then you have to answer those questions in the research.
Okay, ma'am. Thank you.
Madam,
Yes,
can I
any
ask
other
one question?
Yes.
Yes, madam. When we go for the Ayurvedic preparations from the ancient text, so if we collect the that clinical evidences for the same formulation, then can we patent it?
clinical evidences means you want the clinical evidences to be patented?
Yes, please, for the Ayurvedic formulation.
Oh, a position to answer this question because it is a tricky question, right?
Okay, okay, okay. Okay, thank you, ma'am.
Okay.
Anand sir, I want to ask one question. Madam?
Please, sir.
Yes, yes.
Madam, I am Dr. Vivek Srivastav, working as Associate Professor in the School of Pharmacy. Madam, I just want to ask that in India we are 135 crore and
Yes.
every doctor is so much crowded. Even he
Yes.
doesn't have to check the vital parameters of the patient. That is done by his or her assistant doctor or receptionist
Right.
sometimes. So is it possible to implement evidence-based system in India? Or do you think the artificial intelligence or big data has to play a role in this if you want to implement it in India?
We need to have participation from the pharmacists. Artificial intelligence, yes, it is going to help, and we are going to have an era of artificial intelligence. But see, it is not impossible. If you have that conviction, you can implement evidence-based medicine because people can give you an example of simple drugs, like not simple drugs, very vital drugs, angiotensin converting enzyme inhibitors, right? And we have angiotensin receptor blockers, right? It is a well-known fact that angiotensin converting enzyme inhibitors cause cough and angioedema, right? Still, prescribers keep on continuing administering angiotensin converting enzyme inhibitors. Patient land up with cough and angioedema, then they switch over to the angiotensin receptor blockers, right? So, if evidences are being collected and then they are being implemented, I don't think that it will occur in a period. आज हम कल सुबह हम लोग उठेंगे सब जगह पे evidence based medicine हो जाएगा ऐसा नहीं है. Rome was never built in a day. So it has to be a continuous effort. आज से hammer करना शुरू करेंगे तो शायद हम दोबारा जन्म लेंगे तो तब तक implement हो चुका होगा, right? So but it has to be implemented. It is the need of the hour. It has to be implemented. There is no option.
Thank you.
Okay. Any other questions from audience? Okay. Thank you, madam. You have nicely covered this topic of the evidence-based medicine that will be very helpful to our research scholars from their point of literature search to the selecting research problem as well as up to the execution of whole research project. Thank you, madam. As a token of appreciation, we would like to present a certificate to Dr. Kirti V. Patel. So I am sharing just a certificate right now from my screen. I am showing that certificate and presenting to madam. Is it visible screen? Okay. Okay. So same certificate we will send you through email, madam. So with this, I would like to conclude this today's webinar session. Thank you, Kirti madam, from the Parul University.
Thank you.
Okay.
Thank you, Kirti.
Okay. Thank you all participants and students.
Bye. Take care.
Okay. So we can leave now from the session.